Next thing is adjustment disorder. So a woman has feeling low and having difficulty in concentrating since her mother has passed away 2 months ago, and she feels lethargic and being cry more often lately. That's adjustment disorder. Now comes the bipolar disorder. Okay, so the bipolar disorders, these people, okay, say for example, okay, concentrate over here. Let's make it simple. Yeah. So this is our normal mood. Say for example, this is depression and this is mania or hypomania. So these people, they are having a mania or hypomania and they have the depression. Okay. So they have the mania or the hypomania that is alternating with the depression. Mania or the hypomania that is alternating with the depression. Okay. And what you give in a bipolar disorder, that is lithium. That is the lithium. Now, cyclothamia, it's a milder form of bipolar disorder that is fluctuating between the mild depression and hypomanic symptoms. So there is no mania, but the hypomania. Cyclothamia, depression and hypo. That's a milder form, by the way. Need to remember this one. Oh yeah, that's giving you a picture form of what I said. So hypomania, the mania, and the depression. That's a bipolar disorder. So another very beautiful thing is written, like to remember, cannot have a bipolar disorder unless you have both the mania and the episodes of depression. Now we have talked about the lithium. So lithium toxicity, it causes the coarse tremors. That is important, by the way. And the hyperreflexia. Two things which are important to remember, causes the coarse tremors, hyperreflexia, and the seizures and the coma. That's the third thing. So what you do, in mild to moderate, you give IV fluids and stop the drug. And in severe, you have to go for hemodialysis. And you know that the lithium, it causes the Epstein anomaly. Like if you give the lithium to a pregnant lady, it's going to cause the Epstein anomaly. Do you remember what was the Epstein anomaly? Okay. There is the atrialization of the ventricle, okay? The atria is so big, like right atrium, it's so big, and the right atrium is big enough and the right ventricle is small, okay? So it looks like the right atrium has gone into the right ventricle, okay? So that's called the atrialization. On the echo, you're gonna look it like this. So it looks like that. So that is the atrialization of the ventricle. That's Epstein anomaly. Okay, so this is, now comes to delusions. Okay, important. Okay, so the questions about these delusions, literally they are like this. Okay, the things written over here is believing that like the first one, partner is being unfaithful, and they have given you the option. So for the first one is Ehlers syndrome. Okay, these people, they think that, okay, their partners are being unfaithful, are supposed to be unfaithful. With Ehlers syndrome, you need to remember it like this. Then it's grandiose delusion. Grandiose delusion is someone is considering himself or herself, okay, as a big personality or having a lot of money, or he's having a very important position. That's a grandiose delusion. Unilateral neglect, the next one. Belief that one limb or both of the limbs, they do not exist. Delusion of guilt. Delusion of guilt is that somebody is having a belief that if something bad is happened, like the hurricanes or the flood, okay, I'm responsible for that. Then are the persecutory delusions. Okay, persecutory delusions are that these people, they think of the others that they are spying on them or they're plotting against them. Then comes the Equams syndrome. That is about the parasites. You need to remember. Okay, the patient will be saying that he is infested by the parasites. Then comes the erotomania. The simple thing is that somebody is having a belief that somebody, an important position, or somebody like a star, okay, he is in love with me. Okay, that is erotomania. So somebody famous is in love with them. That is erotomania. Then comes the shared psychosis. That is delusional belief and even hallucinations are shared between two individuals who are in a relationship. Okay. Then comes Capgras syndrome. Okay. Somebody, like the few people, they do read it like Capgras syndrome, but actually the P is silent. Okay, it's Capgras syndrome. So in the Capgras syndrome, okay, they believe that the spouse or the friend, they are replaced by some imposter. It's Capgras syndrome. Then comes the free-goal delusions. They have the delusions that the different people are the single person, like 2, 3, 4 people. They are the single people who change their appearance. Then comes the nihilistic delusions. Delusions that a person is already dead and it doesn't exist. Okay, these things you need to remember, like, and the MCQs about these things, they are just giving you a clear-cut idea what it is, but you need to remember the name and what's going on over there. The next one is thought disorders, delusion that are seen in schizophrenia. Okay, there are 4 types of things that are seen in the schizophrenia. Now, basically in the schizophrenia, schizophrenia is there already. So in the schizophrenia, there are auditory hallucinations. There are the thought disorders, okay, which we are going to discuss it over here. And there is the passive phenomena, and there are the delusional perceptions. There are 4 things out there. Auditory hallucinations, okay, what is that? The patient is hearing like 2 or more voices discussing the patient. They have the auditory hallucinations. Then they have these thought disorders like thought insertion. So the patient thinks that somebody is putting the thoughts in my mind. Okay, and there are like 4 types of thought disorders. Thought withdrawal, the second one. Thought withdrawal is that he thinks that whatever I'm thinking, that is stolen by someone else. Then thought broadcasting, like they are conveying their idea directly to the other people. And then there is like thought blocking, that somebody is interfering with my ideas which I'm thinking. Okay, they think like that. Okay, that someone has like blocked the thoughts which are coming into their mind. Okay, then so there were the 4 things as I told: auditory hallucinations, thought disorders, passive phenomena, and delusional perception. So first one, okay, thought disorder, we have done that one. And now comes the hallucinations. So they have auditory hallucinations, first person, second person, okay, or the third person. They could be having the visual hallucinations. Okay, so a diagnosis requires then there's a third thing like passive phenomena in schizophrenia as well. Passive phenomena is their body sensations are controlled by some external influence. The patients think like that. That's the passive phenomena. Then is the delusional perception in these patients. So there are the 4 things. Let me summarize it again. Like the first one, there was the thought disorder, thought insertion, thought withdrawal, thought blocking, and thought broadcasting. Then comes the hallucinations, that could be auditory or the visual hallucination. Then comes the passive phenomena, where they think that their body sensations are controlled by the external influence. And then comes the delusional perception. Delusional perception is that the patient is linking something he's seeing to something, okay, that is not there. Like a patient is seeing a traffic signal, okay, that's there, and immediately he's linking this thing, okay, if it's gonna turn green, okay, I'm the king. It has turned green, so I'm a king. So linking two things, one is there and linking with the other thing. So you can remember it with a sentence that, okay, that traffic light is green, so therefore I am a king. These are the four things. Then there are the negative symptoms as well in the schizophrenia. Okay, they have inability to feel pleasure, they have poverty of speech or the poor motivation. This could be there as well. So diagnosis, it requires two of the following: delusions, hallucinations, disorganized speech, behavior, and negative symptoms. As I said already, negative symptoms. And the symptoms should be there for at least 6 months. So what you give the antipsychotics, okay, and ECT. Now, let's read a little bit about the antipsychotics as well over here. So you have two types of antipsychotics. Those are atypical, okay, and atypical are olanzapine, clozapine, aripiprazole. Yeah. And so atypical are clozapine, olanzapine, risperidone, quetiapine, and aripiprazole, while typical are haloperidol and chlorpromazine. So typical are linked with extrapyramidal symptoms, which I'm going to discuss later. Let's talk a little bit about the atypical first. So generally, okay, the atypical antipsychotics, okay, they are linked with the weight gain, and in elderly people there is a risk of thromboembolism, that is stroke and VTE. But the advantage is that, in contrary to typical antipsychotics, those that are haloperidol and chlorpromazine, there is a decreased risk of extrapyramidal symptoms with atypical antipsychotics. The atypical antipsychotics, they work on D2, D3, D4, and 5-HT receptors, while the typical, they work on T2 receptors. They are D2 antagonists. Now, let's talk a little bit about individual atypical antipsychotics like olanzapine. Olanzapine, that has a higher risk of dyslipidemias. Okay, clozapine, that is linked with agranulocytosis, myocarditis, and it does cause the hypersalivation as well. That's why it should be given only when the other atypical antipsychotics are used, and then you can add it as a second option, but not as a first one. Among these atypical, the aripiprazole, it has a good side effect profile. Okay, it does not cause as much dyslipidemia as compared to the other one. Now, mostly like olanzapine and clozapine, these are linked with the dyslipidemia. So weight gain, that is a side effect. Mostly it's linked with olanzapine, okay, the highest. But clozapine also causes this thing. The other side effects of atypical antipsychotics, these are antimuscarinics, like effects like dry mouth, constipation, urinary retention. They also decrease the threshold for the seizures, and you know that antipsychotics, they are linked with neuroleptic malignant syndrome. So this is as far as the atypical antipsychotics are concerned. The typical one, haloperidol and chlorpromazine, they causes the extrapyramidal symptoms. Okay, extrapyramidal, that is Parkinsonism. That's Parkinsonism, acute dystonia, that is torticollis, like the patient's gonna bend his neck, okay, on the one side, and a coulogaitic crisis. There's up rolling of the eyes, looking towards like the ceiling for like minutes to hours. And the treatment for coulogaitic crisis is procyclidine. Okay, procyclidine. So the first thing was Parkinsonism, then acute dystonia. Then the third one is akathisia, that is severe restlessness. And the fourth one is tardive dyskinesia. Tardive dyskinesia, that is chorioathetoid movements. Chorioathetoid movements, and that is actually a long-term, late onset, okay, after the long term. And one very important thing, okay, antipsychotics, okay, particularly the typical one, they have a risk of okay, increased risk of thromboembolism in the patients. Thromboembolism, you need to remember that one. Antipsychotics, particularly the typical one, thromboembolism, they cause thromboembolisms in the patients. Then is schizoaffective disorder, schizophrenia. They call it schizophrenia as well as schizophrenia. So schizoaffective disorders, schizophrenia plus mood disorder, such as depression or bipolar, and schizophreniform disorder, symptoms lasting in 1 to 6 months. So if it's greater than 6, you can call it schizophrenia, and if it's less than 6 months or greater than 1 month, that is called schizophreniform disorder. Now comes the acute psychosis. So the man is brought to the ED emergency department, agitated, making threats and consider a danger to the others. How are you going to manage? So haloperidol, that is antipsychotic. Then acute psychosis again. So patient is having a history of Parkinson and dementia with Lewy body, has acute psychosis and is elderly. What's the most appropriate medication? I'm lorazepam. Lorazepam is actually benzodiazepine. Okay, lorazepam is benzodiazepine. Alprazolam, diazepam, lorazepam, clonazepam, midazolam, these all are benzodiazepines. Okay. Now comes the haloperidol, that is a typical antipsychotic. So the same thing is there, like it causes extrapyramidal symptoms. Okay, so if the patient is having Lewy body dementia, okay, or the Parkinson's disease, you need not to give the haloperidol because it blocks the dopamine receptor, which worsens the Parkinson's the patient is having. So what is, by the way, what is the Lewy body's dementia? What is Lewy body dementia? So in Lewy body dementia, that's a triad, okay, if you remember. That is cognitive impairment, that's a triad. Okay, in the Lewy body dementia, there's cognitive, can I write it over here? Cognitive impairment, okay, one thing. There is a gait disturbance, and there are the visual hallucinations. That is a Lewy body dementia. Something that is similar to the Lewy body dementia is normal pressure hydrocephalus. There is cognitive impairment, gait disturbance, and urinary incontinence. I'm going to repeat this thing. Lewy body dementia, there's a cognitive impairment, gait disturbance, and the visual hallucination. In normal pressure hydrocephalus, there is cognitive impairment, gait disturbance, and urinary incontinence. So the difference is like visual hallucinations are there in Lewy body dementia. In the normal pressure hydrocephalus, there's urinary incontinence. Incongruent effect. So schizophrenic man is seen laughing and smiling about his father death whom he liked. What term describes his body language? It's important, by the way. Okay, it's different from the others. So someone is laughing at the death of someone who was very close. Incongruent effect. Now comes the clang association. Schizophrenic says that life is unfair. I eat here. Okay, talking about the supernatural things. That's clang association. Okay, life is unfair. Like in a rhythmic way, he is going, life is unfair. I eat here. Lunch here. I like fears. Fears have food. Okay, like something like a poetry. Okay, but making no sense. That's clang association. Now goes pressure of speech. The next one. A 52-year-old woman speaks rapidly without a pauses and ignores interruption. Okay, you do recognize them from their speech without any pause. Okay, I have seen a patient like that. Okay, speaking without a pause, and if you try to cut them because you keep on listening, and then at the end eventually you need to react on them, they barely listen to you. Okay, that